This second part of the video is going to take a closer look at the trigeminal nerve. This is the most important cranial nerve to us because it innervates the relevant tissue, structures, and organs of the head and neck. The trigeminal has three branches. We've been talking about V1, V2, and V3 being part of the trigeminal. The V1 branch is the ophthalmic, and it provides sensation to the upper face and scalp. The V2 provides sensation to the maxillary area, and then V3 to the mandibular area. Take a look at this picture over on the lower right with the 1, 2, 3. Number 1 is V1 at the top of the face, the upper face. V2 is that mid face where the maxillary area is, and then V3 is the lower face. So keep that picture in mind as we're talking about the trigeminal nerve. The trigeminal nerve has these three different branches, and they come through three different areas. So V1 is the ophthalmic branch. It is a sensory branch coming through the superior orbital fissure. V2 is the maxillary branch, another sensory branch or afferent entering through the foramen rotundum. And then the V3, the mandibular branch, is motor to the muscles of mastication, so an efferent branch. And then it's afferent or sensory and enters through the foramen ovale. The sensory portion goes to the mandibular teeth and areas around the teeth. So here is a picture of the trigeminal nerve and the location. We've got the V1 branch. Here's the trigeminal nerve here. The V1 branch going up here to the ophthalmic area. The V2 going to the maxillary area, and then the V3 pathway going to the mandibular area. So V1, we're starting out with V1. This picture is in your book. This is on page 145 in the 6th edition of the Illustrated Anatomy of the Head and Neck. And we have the ophthalmic having three main branches. The frontal nerve, which is further broken down into the supraorbital and supratrochlear nerves. Then we've got the lacrimal nerve, and we've got the nasociliary nerve, further broke down into the infratrochlear, the ciliary nerves, and the anterior ethmoidal nerve, and the external and internal nasal nerves. Now, for the ophthalmic area, the nerve function or the area innervated is the forehead, bridge of nose, and the lacrimal gland for tears. This is a sensory portion. This V1 is a sensory portion, and it is exiting and entering through the superior orbital fissure. These next slides are going to break this down just a little bit more. V1 is the sensory root of the trigeminal nerve, the ophthalmic portion. It's the smallest division, and it's sensory for the conjunctiva, the cornea, eyeball, orbit, forehead, ethmoid, and frontal sinuses, plus a part of the dural matter. The nerve carries sensory information to the brain through the superior orbital fissure of the sphenoid bone. There's another connection. Okay, we know where the superior orbital fissure is, but we have to remember that that is going through the sphenoid bone. So don't forget your bones and the different larger sections. The ophthalmic nerve arises from three major nerves, the frontal, lacrimal, and nasociliary nerve. So here's our branch going to the V1 area, or the number 1 area, and here's the little break-offs for the nerve innervation. So frontal nerve, afferent nerve located in the orbit, composed of a merger of the supraorbital from the forehead and scalp, and the supratrochlear from the bridge of the nose and medial parts of the upper eye and forehead. This nerve courses along the roof of the orbit towards the superior orbital fissure of the sphenoid bone, where it joins with the lacrimal and nasociliary nerves to form V1. The lacrimal nerve is afferent for the lateral part of the upper eyelid, conjunctiva, and lacrimal gland. The nasociliary has afferent nerve branches that converge to form the nasociliary nerve. These branches are the infratrochlear from the skin of the medial part of the eye and the side of the nose, the ciliary nerves to and from the eyeball, and the anterior ethmoidal nerve from the nasal cavity and the paranasal sinuses. Here's kind of a side note. We've talked a little bit about HSV1 and about herpes zoster and shingles being a part of the original exposure to chickenpox. Now this is a unilateral, shingles is a unilateral painful vesicle and ulcer following the pathway of the involved nerve. This area right here, the facial area, is served by the ophthalmic nerve or the division of the V1 division of the trigeminal nerve. We've had several students over the years that have had shingles near their eyes. All of the students had been vaccinated against the chickenpox, but it was lying dormant within the trigeminal nerve ganglion, and it manifested itself near the eye when they got to be under stress, because dental hygiene program, I mean, no stress, right? Here is a cutaway of the different branches of the V1 portion of the trigeminal nerve, cranial nerve 5. And we've got V2, the maxillary nerve division. So the second nerve division of the trigeminal is the V2 branch, and this is the maxillary nerve. And here it is broken down. This is on page number 147 in your book. So the maxillary is further broken down into the zygomatic nerve, which goes to the zygomatical facial and the zygomatical temporal nerves. And then we've got the infraorbital, which further goes to the ASA, or the anterior superior alveolar, and the MSA, the middle superior alveolar nerve. And then another branch off of here is the posterior superior alveolar, or the PSA. Then it goes to the greater and lesser palatine, the GP and the LP nerves, and then finally goes to the nasopalatine nerve. So the maxillary nerve V2 trunk forms in the pterygopalatine fossa by the convergence of many nerves, and it enters through the foramen rotundum. The tributaries of the nerve trunk, which we just saw in that last picture, the diagram, we've got the infraorbital, the zygomatic, the ASA, MSA, PSA, GP, LP, NP, and then the pterygopalatine ganglion. So the afferent nerve branches of the maxillary nerve carry sensory information for the maxilla, the overlying skin, maxillary sinus, nasal cavity, palate, nasopharynx, and part of the dura mater. Carries it to the brain from that area, afferent. There is a ganglion, the pterygopalatine ganglion, which lies just inferior to the maxillary nerve, which is a relay station for the facial nerve. So the first one coming off of that diagram is the zygomatic. It's an afferent nerve composed of the merger of the zygomatical facial nerve, which innervates the skin of the cheek, and the zygomatico temporal nerve, which innervates the skin of the temporal area in the orbit. Then we've got the infraorbital, or the IO nerve, coming out at that infraorbital foramen. That is an afferent nerve which is formed from the merger of branches of the upper lip, the medial part of the cheek, the lower eyelid, and the side of the nose. So all of the tissue areas you're feeling were that infraorbital foramen, all that tissue area right around there. The IO nerve passes into the infraorbital foramen of the maxilla. Passes into the infraorbital, which is the landmark. This is above your first premolar, and this could be an area that's anesthetized. If we anesthetize the infraorbital, it will cover the anterior and middle superior alveolar nerve areas, which we'll talk about in just a second. Because the infraorbital further goes to the ASA nerve, or the anterior superior alveolar nerve, which serves as an afferent nerve of sensation for the maxillary central incisors, lateral incisors, and canines, as well as their associated tissue on the buccal and interproximal area. So if we take a look at this picture here, the orange, it's only showing it on one side, but this would innervate teeth number 6, 7, and 8, 9, 10, and 11, one on each side. And sometimes because there's two different nerves on each side, so 6, 7, and 8 is one ASA branch, and then 9, 10, 11 is the other. Sometimes right in between 8 and 9 there is a little bit of crossover on the contralateral side for the patient, and it's just an overlap of some of those nerve fibers. We talked about that a little bit more in class, just like the anastomosis of the arteries and veins across that area. There can be some feeling or some sensation from a kind of a rogue nerve in that area. So the ASA nerve receives interdental branches from the surrounding periodontium, and it forms a dental plexus or nerve network in that area. The landmark is the height of the mucobuccal fold at the apex of the canine. So this is where we would be giving the injection for preventing the propagation of a nerve impulse down that ASA nerve. We would be giving the injection right there to stop any action potential. The MSA, we can see in the green picture here, or the green on this picture here, the MSA serves as an afferent nerve of sensation for the maxillary premolar teeth and the mesial buccal root of the maxillary first molar and the associated buccal gingiva and interproximal gingiva. So on each side, that would be teeth number 4, 5, and the mesial buccal root of 3, and then that would be 12 and 13 and the mesial buccal root of 14. Not everybody has an MSA nerve. It's missing in 28% of the people. If that nerve is not present, the area is innervated by the ASA and the PSA, mainly the ASA. If the nerve is present, there's communication between the MSA nerve and both the ASA and PSA. If we were giving an injection in that area, height of the mucobuccal fold at the apex of the second premolar, and we would be numbing those premolars and the mesial buccal root of the first molar. The PSA, we've been talking about the PSA before because we had to know where the posterior superior alveolar foramen is, and that is on that backside of the maxillary tuberosity of the maxilla. And the PSA is going to innervate this yellow area on top, so the molars plus all of the molars, except for, not plus, but except for the mesial buccal root. So we've got 1, 2, and number 3, except for the mesial buccal root of number 3. Then we've got 16, 15, and 14, except for the mesial buccal root. And the injection for the PSA, or the posterior superior alveolar, would be height of the mucobuccal fold distal to the second molar, and we're trying to get to that foramen kind of around that back corner. Here is your maxillary nerve review, or your V2 area, and where it goes to. This picture is in your workbook. Here it is a little bit closer, so you can label this. This would be a good picture to color and label for studying purposes. Now we've also got on the maxillary, we've got the greater and the lesser palatine nerves. So we're looking at these coming through the greater palatine foramen, which is the anterior foramen that is anterior on the hard palate area, and then the lesser palatine foramen is the one towards the soft palate. So those are the two in the back. So the greater palatine nerve enters through the greater palatine foramen, and it innervates the palatal tissue, hard palate tissue, on the lingual of the maxillary posterior teeth. The lesser palatine nerve enters the lesser palatine foramen and innervates the throat region, palatine tonsil, soft palate, and uvula. If you are numbing a patient and you go too far posterior, the patient might complain of their throat being numb. So I kind of did the little, oh, my throat feels like it's numb. That's what the patient will tell you if you have deposited the anesthesia too far to the posterior. The anterior, more anterior foramen is the greater palatine, the more posterior is the lesser palatine, but they're a very close proximity to each other. And then here is where our GP is, so our greater palatine. Our greater palatine is just doing the tissue of the posterior hard palate, just the tissue from the teeth to the midline. So you would need one on each side. And then here's the picture where there's the two openings or foramen towards the rear of the hard palate. The one further forward is the greater palatine, and the one towards the back is the lesser palatine. Alright, here would be your injection spot for the greater palatine. You would be anterior to that greater palatine foramen. There's a soft depression that we'll find. We kind of follow the second molar down, and then we would be numbing that tissue. If a patient was having sensitivity while we were doing some scaling and root planing or deep scaling on that palatal area or that lingual of the maxillary teeth, we would be able to numb the tissue with this injection, because we would be stopping the action potential from propagating from this palatal area. Then we've got the nasopalatine. The nasopalatine nerve originates in the mucosa of the anterior hard palate, lingual to the maxillary anterior teeth, the maxillary central incisors. So this nasopalatine nerve comes through the incisive foramen, our pizza burn spot, right behind lingual to number 8 and 9. So nasopalatine nerve comes through the incisive foramen and is covered by the incisive papilla. And we, in fact, when we're numbing this area, we're going into the fattest part of that incisive papilla to numb that area and stop the action potential going to the brain from that area. So here's a picture of our incisive papilla, and it's covering our incisive foramen, and that is going to numb, or the nerve going through there, the nasopalatine nerve, is going to innervate that whole triangle section that is the anterior hard palate. So one injection, one nerve. This is the only area where there's one nerve. All of the rest of these have one on each side. So the nasopalatine nerve comes through the incisive foramen and innervates this anterior little segment here to numb the anterior hard palate right behind 6 through 11. And here's where the injection would be, near that incisive foramen in the fattest part of the incisive papilla to numb the nasopalatine nerve. Alright, then we've got our V3 branch. So our V3, or our mandibular branch, it is going to break off further into the buccal nerve, the muscular branches, the auriculotemporal nerve, the lingual nerve, and then the IA, or the inferior alveolar nerve. From the inferior alveolar, it's going to go further into the mylohyoid nerve branch, then the mental nerve, and then the incisive nerve. So this is the third division, the V3 division of cranial nerve number 5, the trigeminal nerve, and it exits through the foramen ovale of the sphenoid bone. This needs a big spot because it's got a motor branch and sensory branch. It's found within the infratemporal fossa, deep to the base of the skull, before the nerve passes through that foramen ovale of the sphenoid bone. The mandibular nerve joins with the ophthalmic and maxillary nerve to form the trigeminal ganglion of the trigeminal nerve. So we've got this ganglion, this big branch right here. And our V3 branch is going to cover that mandibular or lower part of the face. This is the largest of the 3 divisions, and it's a mixed nerve with afferent sensory and efferent motor. The efferent part motor to muscles of mastication is within this V3 area. So we've got the buccal, the muscular branches, the auricular temporal, lingual, the IA, which further branches into the mylohyoid, the mental, and the incisive. So here's a closer picture of it as it's branching off. It's coming down here. The anterior division of the mandibular nerve is formed by a merger of the buccal nerve and additional muscular nerve branches. The anterior trunk has both afferent and efferent nerves. The buccal nerve, or the long buccal nerve, is located on the surface of the buccinator muscle. It innervates the skin of the cheek, the buccal and interproximal gingiva of the mandibular molars. We'll see that on our picture in a minute, our colored picture in just a minute. When we're doing a buccal nerve block, we are at the occlusal plane of the most distal molar of the mandibular arch, and there's a spot right next to the retromolar pad, anterior to the border of the ramus, which is our landmark. So right here. We have our muscle branches, the deep temporal, masseteric, and the pterygoid are muscular branches that are part of the anterior trunk of the V3. They arise from the motor root of the trigeminal nerve. So deep temporal, masseteric, and then our medial and lateral pterygoid are our muscles of mastication. So those muscular branches go to the muscles of mastication. That's one of the anterior trunks of the mandibular nerve. Here's just an overview picture. And then we've got the posterior trunk. So we've got a posterior trunk going to the auriculotemporal with afferent fibers for the external ear and scalp. We've got the lingual nerve, afferent nerve, sensory nerve for general sensation for the body of the tongue, the floor of the mouth, and the lingual gingiva of all of the mandibular teeth. This lingual nerve is also anesthetized when administering an IA block because the lingual nerve comes into the area at the same place where the IA does, and if you are numbing the IA to give a lower block, then it diffuses to the lingual and numbs the lingual that way. We never directly numb the lingual, but just by the diffusion of local anesthetic, we get some anesthetic and some blocking of the nerve impulses from the anesthesia in that area. We have the inferior alveolar, or the IA. This is our lower block. This is an afferent nerve which is formed from the merger of the mental and incisive nerves. So the mental is chin, and the incisive nerve branch is that last little branch that goes from the mental foramen area all the way to the midline. After forming the IA nerve, continues to travel posteriorly through the mandibular canal along with the inferior alveolar artery and vein. The IA nerve exits the mandible through the mandibular foramen, where it's joined by the Mylohyoid Nerve. The Mylohyoid Nerve is going to the mylohyoid muscle, and you can see here it's coming off the mylohyoid groove above the submandibular fossa, just to give you an idea of where the IA is coming through. The IA carries afferent sensory information for the mandibular teeth. So if we were thinking about what the IA innervates, it's all of these lower teeth to the midline. It does not innervate this buccal gingiva of the posterior mandibular molars. That is the buccal nerve itself. So if we were wanting to numb somebody to work on one quadrant, and in this picture it would be quadrant 4, if we were wanting to numb this whole quadrant, we would need to do the IA injection in the back here, And then we would also have to do a buccal injection to get that buccal gingiva anesthetized. And so here's another layout to take us back there. So the IA, we're down here, and then we've got several different parts, the mylohyoid, mental, and incisive. So the mental nerve enters through the mental foramen on the lateral surface of the mandible. So right up here, usually between the mandibular first and second premolar. And it has external branches that serve as sensory nerve for the chin, lower lip, and labial mucosa of the mandibular premolars and anterior teeth. The mental is just the skin and the tissue. The mental nerve enters the mental foramen on the lateral side of the mandible, and that would be a landmark for a mental block. The mental block given in that area is just going to numb the tissue. We have to massage it into that mental foramen, massage the anesthetic into that mental foramen to get that to go to the incisive nerve to actually numb the teeth. So the incisive nerve is a sensory nerve composed of the dental branches from the mandibular premolar and anterior teeth that originate in the pulp, exit the teeth through the apical foramen, and join the interdental branches. So that incisive branch is the teeth and the tissue. We're numbing in the same place at the mental foramen, but we're massaging it in to get to the incisive portion or the terminal branch of the IA nerve. So here's where in the blue down here on the bottom, this is where our incisive nerve branch would innervate, going from the mental foramen to the midline. If we did not massage it into that mental foramen for it to get to the incisive branch of the IA nerve, then it would stay and just do the tissue. Again, if we were just numbing one side, we may have some innervation, some crossover from the other side between 24 and 25, just like we would from 8 and 9. So here's where the incisive block would be. Same place as the mental foramen, but we would massage it into that mental foramen so that it would stop the depolarization of the incisive nerve area. Here's the mylohyoid nerve. So the mylohyoid goes to the mylohyoid muscle, efferent to the mylohyoid muscle in the anterior belly of the digastric muscle. The posterior belly of the digastric is innervated from the facial nerve. And in some cases, this is an afferent or sensory branch for the mandibular first molar. So if a mandibular first molar doesn't get numb, sometimes there can be some innervation from the mylohyoid nerve to that tooth. If there's a concern, the mylohyoid nerve can be additionally anesthetized by giving a supraperiosteal injection at the apex of the mesial root of the mandible. We'll talk about that a lot more in local anesthetic. All right, two things to associate with the trigeminal nerve, cranial nerve number 5, are trigeminal neuralgia, or tic de la Rue. There is no known cause, but it involves the afferent nerves of the 5th cranial or trigeminal nerve. It usually involves the maxillary or mandibular nerve branches, but not the ophthalmic branch. And it's very painful. One theory is that this lesion is caused by pressure on the sensory root of the trigeminal ganglion by area blood vessels. Clinically, the patient feels excruciating short-term pain when facial trigger zones are touched. Sometimes they feel it when they're speaking or chewing, setting off muscle spasms in the area. Pain provokes brief muscle spasm of the facial muscles, thus producing the tic. So that's why it's used to be referred to as tic de la Rue. So trigeminal neuralgia. And because there are a large number of conditions that can cause facial pain, it's really hard to diagnose, but finding the cause is important because patients really have a lot of pain, and different kinds of treatment then can differ based on their symptoms. Treatment can include medications such as anticonvulsants or tricyclic antidepressants. Some patients have surgery, and some will do some massaging, that kind of thing. Typically, analgesics and opioids are not that helpful in treating the sharp pain that's caused by trigeminal neuralgia. Here's another side view picture of the trigeminal nerve. Here is the mandibular nerve with a lateral view. Another picture of it with a cutaway. And here's from the medial view. Here's another picture you should know. Just some pictures to kind of get your orientation. I'm going to stop right there, and then we'll come back to the facial nerve.